Hello, my name's Kimberly, and I'm here today to describe how to develop a plan for a pediatric surge emergency. A pediatric surge emergency happens when we have more pediatric patients to treat than resources in a hospital during normal operations. Let's look at some key concepts in surge planning. Your organization needs to understand the various spaces you have to work with, the staffing needed to manage more patients, and the stuff like supplies to care for those patients. Along with space, staff, and stuff, we need your ideas, your time, and partnerships to meet our planning needs before an event, and your commitment to respond if there is an event. But first, a bit about our current situation in Oregon. Children make up almost a quarter of Oregon's population. However, when we look at healthcare resources for the sickest children, the disparity is evident. Kids are lower to the ground, they have a higher surface area to volume, they have higher ventilation and metabolic rates, and a large head compared to their bodies. Developmentally, they are dependent on adults in disasters, and they may not have access to a capable adult. In fact, hospitals will see a larger number of children than they normally do for post-disaster care. But the good thing is, with early care, children will get better faster from their injuries than adults will. For a hospital to make a surge plan, there are key pieces of information needed before you actually start doing the planning. First, develop an understanding of what your current care capacities are for children across all areas of your hospital. A survey is a great way to gather this information. In spring 2017, surveys were distributed to the 3 pediatric specialty care hospitals. We assessed operations in 11 areas of each facility. The data was combined to develop a comprehensive regional picture of care capacities to share with partners in order to develop a regional surge plan. Let's take a look at an example from this survey. To begin, we assessed the number of pediatric acute care specialty beds at 3 hospitals: Randall Children's, Dornbecker Children's, and St. Vincent Medical Center. Each hospital reported the total number of licensed beds for this level of care. Starting with each hospital's licensed bed level, we applied the 20% and 50% increase calculations for immediate bed availability and contingency bed levels, respectively. Regionally, we now know what the total number of beds could be for this level of care in a large-scale disaster. Secondly, work with your local emergency management office to understand what hazards are in your community and what the likely impacts are, including injury estimates. This will help you understand your resource limitations and the potential demands. We tend to plan for 2 types of scenarios for a pediatric surge. One is a trauma and injury model that would result from a transportation accident, an earthquake, gun violence, or a fire. This is sometimes called a mass casualty event, and surgical services would be in high demand. The other scenario we look at is one of a pandemic disease impacting children more than adults. The resources needed for this would be very different than those for a trauma care incident. Likely, it's pharmaceuticals, hydration supplies, and ventilation. Finally, developing a planning goal is critical. It is hard to plan for something if you don't know what you're aiming for. Next, I will describe the levels of surge goals to help you in your planning. To make regional planning for pediatric surge easier, the project's leadership group reviewed the literature for best practices and developed the following recommendations. Here we have what we call a surge pyramid. The pyramid begins at the base with licensed beds. This number is likely more than your average staff beds, but it's a common place to start for regional planning. The second level of the pyramid is what we call immediate bed availability. This standard is a federal requirement for hospitals to increase their capacity by 20% of licensed beds within 4 hours of a declared emergency. The third stage is the contingency phase. Contingency planning should strive to expand the operations by 50% of the licensed bed level. In this area, we would likely see changes to standards of care and supply use rationing or standardization, and perhaps using non-traditional spaces for patient care. The fourth stage is the crisis phase, which is likely a catastrophic scenario that the patient care load is above the contingency level plans and can span up to 4 times of licensed bed levels. Now that we've talked about what we need to know to inform our planning, I will describe what a comprehensive planning process can look like using a toolkit to guide your planning. The 5 phases of the planning process break up the planning activities over a longer period of time. It will likely take a year or 2 to complete the entire process. Let's look closer at each phase. Phase 1 involves the emergency manager reviewing the toolkit with the Emergency Management Committee and determining assignments for the tasks listed on the hospital-wide planning worksheet. Phase 1's process is guided by worksheet number 1 in the Pediatric Surge Planning Toolkit. Its intention is to help you identify planning considerations, policy that needs to be created, and decisions that might need to be made in order to guide future surge planning efforts across the organization. The second step in planning is at the inpatient unit level. Using the space, staff, and stuff model, unit managers will be determining how they will change operations to meet the challenge of expanding their individual unit's bed capacity by the 20 and 50% standard. Here, in an excerpt from our second worksheet, we see the space section. The unit manager places their target bed capacities across the top and identifies space options for placing patients and which spaces will be used for supply storage. Each worksheet in the toolkit comes with a robust example to help you. Phase 3 of the planning process is for support services. We know that if we increase patient beds in the units, the hospital's units that support them, like dietary and laundry, need to surge as well. Another example of support unit is one that provides patient care at the bedside rather than in a fixed location. This is a segment from worksheet 3. This example is for a respiratory therapy unit that has to support 20 and 50% more patients. How will they add more staff and supplies to their service area? The worksheet helps them solve the problem and identify potential solutions to solve their shortages. It's quite an accomplishment to get your organization through those first 3 stages of planning. However, to make the move from planning worksheets to a real plan, we need our emergency manager and hospital executives to help finalize the work done by everyone else. The emergency manager reviews the submissions from all parts of the hospital and determines where there are discrepancies, gaps, policies that need to be created, or space conflicts between all the worksheets submitted. To resolve these items, executive leadership is required. After the executives are consulted, the emergency operations plan and its related policies may need to be updated in order to finalize the strategies identified in previous planning. Here, our emergency manager is using the toolkit's planning spreadsheet to enter all of the identified bed numbers, space requirements, staffing needs, and supply projections into it to create a hospital-wide picture of what is needed to meet the surge targets for various scenarios. A major step in finalizing a plan is to run drills and discussion exercises on different areas of the plan and adjust it as necessary. Having a written plan is a great start, but it is the act of planning that is essential to success. Remember, a plan is a living document, and it must be continually tested and refined to ensure it's still accurate and realistic for the organization. Don't just let it live on a shelf. It's important to run exercises. Well, that certainly was a lot to cover. Some things to remember are to keep your focus on space, staff, and stuff, support and help each other with planning challenges, and finally, know that you're helping your community be more resilient and recover faster from an emergency. Good luck!